Today we will look at a very interesting case, and we will see how things are very important. Particularly focus will be on ECG. So okay, so this is a 40-year-old male with history of Graves' disease, suffering from paroxysmal atrial flutter. So obviously Graves' disease, thyrotoxicosis, they can have arrhythmias, and this patient was having paroxysmal atrial flutter. There was no risk factor for coronary artery disease. Patient visited OPD, cardiology OPD, with complaints of uncomfortable palpitations. So patient had some uncomfortable palpitations, patient was not comfortable, so patient went and visited cardiology OPD, and while waiting outside the OPD, patient collapsed. So this is what happened with the patient. So obviously immediately after doctor came and checked pulse, blood pressure. So basically pulse and blood pressure was not palpable. So immediately CPR was started and patient was rushed to the emergency. In emergency, DC shock was given, which reverted, and patient blood pressure became palpable, but pulse was irregular and with some tachycardia. So this is the picture, right? This is the ECG. So can somebody say what it shows? What does the ECG show? Anybody?
VPC.
Okay, VPC. So which one is VPC and which one is, all are VPC or some VPC and some normal? Some normal. Why, which one is VPC? Come and tell, which one is VPC? This is VPC. Okay, why VPC?
So broad QRS with
broad QRS. Okay, and from what side is it coming? Any guess? Can you calculate the axis?
right axis deviation.
Right axis. So VPC can come from, if there is a right axis deviation, then
From right.
right? Okay, read it. So one is that there is VPC. Any other abnormality? Any other abnormality you see on ECG?
Broad QRS.
No, broad QRS, this is because of VPC. Anything else you see? So once you see a ECG, what are the things you look at? First is standardization. There is no standardization, so you can't look for it. Second thing you look for? Regular or irregular. So this is what? Irregular. Then if it is irregular, then what are other things you look?
Presence of T wave.
Rate. So what is the rate? What is the rate? How do you calculate the rate?
Large burst in between the error interval.
So if you look, let us say, let us take 2 sinus, if you can see, if not then, so this VPC is coming at what rate? But if you look at VPC itself, then 75. So rate looks okay. In one part it is fast, but overall maybe it is okay rate. But what is the other thing you look at? You were talking about something? P wave. So where do you see the P wave?
Second and P1.
You can, so you can somebody come and show me the P wave? So no P wave. So then what is the diagnosis? Atrial? Atrial? AF or atrial flutter? Atrial flutter? Fibrillation. Why not flutter?
Flutter P wave.
because in flutter you will see something like this. You will see the flutter wave. P will be sawtooth shape. So this is not. So this is atrial fibrillation. So what you see in ECG? At least two abnormalities. You see AF and also you see VPC. So what is the source of AF? Where is the AF generated? Atria. And where is VPC generated? Ventricle. So two parts of heart are involved, obviously. Atria is also involved and ventricle is also involved. And it cannot be because of slow heart rate, because heart rate is not slow. So once what can happen is, if the heart rate is very slow, then sometimes ectopics take over if it is very, very slow. So if there is a sinus arrest, then or AV block, then sometimes ventricular takeover. But this is not a slow heart rate also. This is a regular heart rate. So the reason is not slow heart rate. So two parts of heart seem to be involved, atria and ventricle. Next. So this is ECG after resuscitation, and it shows presence of AF and VPC. And the third thing, what you see? AVL, V1, possibly Q wave also on the anterior lead, right? Next. Then in hospital, patient developed paroxysmal complete heart block. So what does complete heart block mean?
P and QRS are not very well.
That's okay, but what it means, from structurally what organ is involved?
AV node.
AV node. So atria is affected, AV node is affected, and ventricle is affected. So it helps you in deciding the etiology, isn't it? Is it possible in coronary artery disease? Can coronary artery disease affect atria, AV node and ventricle? Can it?
In inferior wall MI.
Sorry?
In inferior wall MI.
Is there inferior wall MI?
Triple vessel disease.
Triple vessel disease will affect ventricle. Why will it affect atria and AV node? Triple vessel disease will affect ventricle, no, predominantly. So very extensive coronary artery disease can.
Left main.
Very extensive coronary artery disease, end stage coronary artery disease can. But here, is there any evidence of very extensive coronary artery disease on this ECG?
T wave
Does that decide?
AVR.
Extensive means end stage heart disease. So what does ECG of end stage heart disease show? What is the main thing? Suppose ejection fraction is 10%, 5%. What will come on ECG?
Wide QRS.
Wide QRS. So here, is this wide QRS? So does it suggest coronary artery disease? I mean, it cannot be 100% sure, but does it suggest? No. So it suggests something else. So I am only trying to make you think that you look at ECG, many things can come out of ECG itself if you think. That you have to think is, patient has got three types of rhythm disturbances: AF, VPCs and complete heart block. Very odd. Three types of rhythm disturbance. Very extensive heart disease, as he said, left main, triple vessel disease, poor ejection fraction, everything gone. Then you can have something like this. But patient is like, go back. Patient never had any symptoms. Patient has just come with palpitations. So इतना extensive coronary artery disease होती तो history तो थोड़ी फर्क होती ना. Patient should have something. Moreover, the जो उसकी sinus वाली beat है या जो ventricular जो real beat है वो उसका QRS prolong नहीं है, which can tell you कि at least ejection fraction is not very, very low. It could be low, but not very, very low. So all this and patient is not in heart failure kind of thing with poor. So all pointers not in direction of CAD. Still possible, but less chance. So what can be the cause? If it is not CAD, what can be the cause? Can infiltrative heart disease cause this kind of problem? Suppose there is infiltration, suppose there is amyloidosis, suppose there is sarcoidosis, suppose there is something else. Can it cause this kind of problem? Infiltration occurring in atria, in AV node, in ventricle, can it cause this kind of problem? Can? But is it fitting? Why is it not fitting? All three simultaneously affected. It can happen that has something, then something, then something. Here you see simultaneously, although there is a history of AF, so possibly, but flutter, not AF. So all the three simultaneously affected, and if so much infiltration has happened, then patient has to be very sick, isn't it? If so much infiltration has happened that ventricle is also infiltrated, atria is also infiltrated, AV node is also infiltrated, then patient has to be very sick. Patient is not that sick. So fit everything. So my idea is to just excite your imagination that whenever you see a patient, try to see what things are fitting, what things are not fitting. If things are fitting, then intuitive intelligence, you just make the diagnosis and that's it. If things are not fitting, then how do you reason about the things? So that is the idea. So one ECG gives you interesting insight of things that you don't understand, that you don't know, but you start reasoning what could be the problem. So what could be the other problem? So it looks like CAD possible, but very less chance. End stage heart disease possible, but very little chance, because the very fact that patient was quite okay and suddenly he developed this. So end stage cannot happen suddenly, no, it can happen over a long period of time. Likewise, severe triple vessel disease with left main, etc., severe atherosclerosis can happen, but it will not happen suddenly. Infiltration possible, can affect all the things, but then patient presenting suddenly without any prodrome except that history of Graves' disease, that's all. So unlikely. So now let us just think, a patient has Graves' disease. What is the cause of Graves' disease? Thyrotoxicosis, what is the cause? So it starts with thyroiditis and manifests as thyrotoxicosis and then moves into hypothyroid. So as you said, some kind of autoimmune process possible which causes inflammation in thyroid. So it causes inflammation in thyroid. So if you look for any heart failure with, let us assume it's a reduced ejection fraction, we have not still done echo, but any person who has presented, what are the causes? So idiopathic could be one, coronary artery disease, inflammatory cardiomyopathy. So inflammatory cardiomyopathy is one possibility. Infiltrative, as I said, possible, unlikely. Valvular, again not likely, because one valve can affect one part. Can, suppose it is mitral regurgitation or something, then it can affect LV. But why will it affect atria? Why will it affect AV node also? So not likely. Tachycardia induced cardiomyopathy can cause tachycardia, it can cause heart failure, but it will not cause AF, complete heart block, VPC, etc. So that is not likely. Cardiotoxic agents, if there are certain drugs, they can, because they can affect both atria, ventricle, AV node, etc. But what drug? There is no history of drug intake. Likewise, the other possibility, fulminant myocarditis can happen, but here patient is not presented with heart failure predominantly. Patient has not presented with sudden breathlessness. Patient has presented with palpitations. And the three things again, complete heart block, AF and VPC, all three happening together, tells you that there is some inflammation. There is some inflammation which is affecting the heart. Okay. Now what can be the causes of inflammation? Could be autoimmune, as you said, Could be infection, and what else? Infection or autoimmune. These are two possibilities, right? Other things are not applicable here because the presentation is much different. So now we have to think of inflammation or infection. Now, if it is infection, why it affects only heart? Because patient has only presented with heart. No other organ is involved. There is no fever. Okay. There is no evidence of any other organ involved, or past history of some thyroid involvement, but no other organ is recently involved. So, do you know of any organism that affects only heart, and that too complete heart, atria, ventricle, AV node, all the three parts of heart, but not affecting any other organ? You know of something? Coxsackie. So, could be myocarditis, but as I said, myocarditis generally myocardium. AV node is also affected, and atria is also affected. So, anyway, we will come to that, but any other thing you said? Autoimmune? Syphilis. Syphilis. No history of contact. And syphilis also presents with aortitis. SLE? SLE can, what does SLE commonly cause? No, nephritis, their heart, what part of heart it affects mostly? Valves, no? It affects valves only. But here there is no evidence of valve, here there is an affection of myocardium. So, SLE causes myocarditis. It causes vasculitis, but not necessarily myocarditis. So, SLE unlikely. RSD, rheumatoid arthritis. So, it causes myocarditis. It also affects what? It affects valves mostly, no? So I think it gives you something to think what it can be. Next. So, obviously, now you have to investigate. So, these are the routine investigations as you notice. So, some are cardiac specific, some are this. Of course, echo is important, X-ray, MB, to see whether myocardium is damaged, because you are suspecting myocarditis. So, see whether myocardium is damaged. LFT, if liver is also affected, then you might start thinking of infiltrative. If urea creatinine is effective, you can think of nephrology involvement also, and so you think of disease where both kidney and heart is involved. If liver is there, then you think disease both heart and liver is involved. If liver is involved, then you start thinking of maybe malignancy also. But although malignancy will not present like this, malignancy, none of the malignancies presents with palpitations and AF, VF and complete heart block. Obviously, patient also had VF, that is why patient had sudden cardiac arrest which required defibrillation. So, patient also had VF. So, AF, VF, everything. Which malignancy? Very late stage of malignancy, cardiac involvement. So, but other things, then you start looking for coronary artery disease, unlikely I told you, but still you want to rule out. So, you do. MRI is a very good important investigation, because here that will help you decide what part of myocardium is affected. If it is subendocardial, then it could be because of coronary artery disease, but if it is pan myocardial, then it could be something else. It could be some other kind of inflammatory diseases are possible. Subepicardial, then inflammatory disease. So, depending on MRI picture, that will help you decide what kind of disease process it could be. And then of course, if it is malignancy, then PET. If it is inflammatory or autoimmune, then serology may be important, because autoimmune is a possibility. No, autoimmune, infective, these are possible. But and then finally, of course, if you can't make any sense, then you have to take biopsy and then look at the biopsy. So, these are all the possibilities that you would do in this kind of case. So, let us look at what we have. Hemoglobin 9.6, urea creatinine slightly elevated, SGOT-PT also elevated, troponin also elevated, CK-MB elevated, total CK elevated, X-ray shows cardiomegaly, echo shows ejection fraction of 25 to 30%, which we were suspecting anyway. In heart failure we were suspecting, although not presenting. Coronary was done, which was normal coronary. Now, MRI shows inferoseptal akinesia of distal part of myocardium in LV, and this is something called late gadolinium enhancement, which is very important, and LGE was found in subendocardial almost transmural pattern. So, this is what it shows. So, here you see this. So, this type of picture, but the picture is not fitting into any coronary tree, also it is coronary we know is normal. So, what does it show? There is part of the myocardium involved with most likely some inflammatory kind of myocarditis. This is what it shows. Next. Then serological tests were done because we were suspecting. So, myositis specific antibodies were looked for, and then other type of antibodies for neuromuscular disease were also looked for. Whole body PET was also done, which was normal. All the antibodies were looked for, but nothing was found, and this is the PET for this patient. So, you can see when complicated patients where it is not, then you have to do many investigations to decide, but PET did not help. Serological tests were negative, no myocyte specific autoantibodies were found. So, then when everything done, you can't find anything, you have to do endomyocardial biopsy. So, this endomyocardial biopsy and muscle biopsy both were done, because remember CK was also raised, and so the muscle enzymes were also raised and cardiac muscle enzymes particularly were raised. So, both biopsies were done. Muscle biopsy showed fiber variability, cell necrosis compatible with immune mediated necrotizing myopathy. So, now you are able to make the diagnosis of immune mediated necrotizing myopathy, and that is why, because muscles, person has got cardiac problem, is already not moving. So, muscle symptoms are missed, only cardiac symptoms are apparent, but it is inflammatory disease, autoimmune mediated against both skeletal muscle and cardiac muscle. Histopathological image of endomyocardial biopsy also shows mild to moderate hypertrophy, replacement of fibrosis with endothelial proliferation, inflammatory cells. So, again myocardium also showing inflammatory cardiomyopathy and muscle showing inflammatory myopathy. So, now we know it is inflammatory myopathy, most likely of immune origin. Next. So, now let us come to what is the prognosis. So, I wanted to share this with you because you need to know, when you see any heart failure patient or somebody with cardiomyopathy, you need to decide whether this patient is going to live long, because cardiomyopathy patients with ejection fraction 10%, 20% may survive for even 20 years. Lot of patients we have seen can survive for 20 years more. On the other hand, people with just 30% ejection fraction, you won't think is much less, they actually die quickly. So, ejection fraction is important, but not that important. So, there are other factors which decide prognosis in heart failure. So, this is important. So, one is clinical factors. If patient has got lot of symptoms, here patient, remember, had sudden cardiac death. So, this is like highest of the symptom already. Then you look at biomarkers. Here biomarkers you saw was markedly raised. And then recurrent hospitalization, well, that we do not have that much, but progression of heart failure, if suppose previously ejection fraction was 30%, now it is 10%, so there is progression, then that is also. Then if blood pressure drops, forward flow is decreased, if there is evidence of arrhythmia, which three types of arrhythmias are there, VF, AF and complete heart block. So, this, and then if there is inflammatory pathology for any reason, that itself is a higher risk factor, and then anemia also present here and renal failure also present. So, you see in this patient practically all the high risk features are present. Patient has had a history of sudden cardiac death along with heart failure, biomarkers are elevated, CK-MB and CK-2530, evidence of three types of arrhythmias, evidence of inflammatory myositis already seen on biopsy, anemia also present, renal failure also present. So, patient has most of the factors that worsen the prognosis in heart failure, and this patient has a very, very poor prognosis, although he might have survived after this shock, but this person has a very, very poor prognosis. So, what to do? Obviously, you have to attack the disease in with as much strength as possible, because patient is very, very sick, and if you don't do the thing, then patient may not survive. So, cyclosporin, obviously steroid is treatment of autoimmune diseases, so steroids, but you can't only rely on steroids because patient is very sick, and you have to understand that all the high risk features are present. So, you add cyclosporin to steroid, but again problem was that despite all this nothing much was happening. Then this AMA test was done, which is anti-myosin antibody. So, specifically against antibody against myosin, and which is present in both cardiac muscle and skeletal muscle, and we find that it is hugely elevated, more than 220, normal value is 4. So, it is AMA associated inflammatory myositis affecting both heart and skeletal muscle, but basically we are worried about heart. So, with this grave kind of positivity of this test, AMA test, rituximab, which is monoclonal antibody, was started, but unfortunately no cardiac improvement happened, and patient actually died due to chronic renal impairment and later liver failure also, which you already saw was started happening because patient could not undergo cardiac transplantation. So, this is finally died of septic and cardiac shock. So, this was a much could not be done, but what I wanted to show you in this case is how you have to make the decisions, and what all you should have in mind while making diagnosis and trying to treat, prognosticating the patient and treating the patient. Next. So, what did we learn? So, whenever we come across heart failure, it is very important to look for cause, because if you can identify a cause, probably you can treat it. If you cannot identify a cause, then problem. Like in this case, we missed the diagnosis for long, although we were suspecting, but we could not pinpoint what is the exact. If rituximab was given at an earlier stage, maybe, don't know anyway, because all the prognostic factors were high risk. So, we don't know, even if with best treatment patient could have survived, but at least it is important to establish the etiology. Then recognize high risk features in heart failure. I told you those high risk features, those features you should recognize, and if you see them, then immediately start acting. Inflammatory myocarditis, myopathy is a heterogeneous disease affecting skeletal muscle, but can also affect myocardium, like in our case. Anti-mitochondrial antibodies, AMAs, is a hallmarker, which is a hallmark of primary biliary cholangitis, exists as a subgroup and may predict very serious cardiac involvement. So, remember, AMA anti-mitochondrial antibodies are hallmark of primary biliary cholangitis, but they can present with serious cardiac problem, as it happened here. And anti-mitochondrial is a rare disease. Prevalence is about 11%, about 1/10 of inflammatory myocarditis is of this type, and cardiac involvement is a polymorphic arrhythmias, cardiomyopathy and heart failure, and muscle biopsy helps. More important is to be aware of this problem, that sometimes you can come across this group of patients of inflammatory myocarditis, which is AMA, anti-mitochondrial antibody, because muscle etc. antibodies were tested, but anti-mitochondrial antibodies were not tested, and it is important to, and this has a very grave prognosis, as we already saw. Next. So, if you look at causes of mortality in any acute decompensated heart failure, it is of course, if it is of rapid onset, less than 1 month duration, then it can be cause. Then if comorbidities are present, lot of comorbidities, if liver is also gone, kidney is also gone, that sort of thing, then obviously you will have comorbidity. But this IM, inflammatory myocarditis, is especially a very bad prognostic cause and leads to high mortality. Then associated renal failure, arrhythmia, anemia, overload, decay, etc. Then these are the possibilities. So, I think we will end here.